Hello and welcome. My name is Sue Stewart, and I will be your moderator for this workshop, Bone Marrow Health and Other Endocrine Issues After Transplant or CAR T-Cell Therapy. It's my pleasure to introduce today's speaker, Dr. Angeliki Stamatouli. Dr. Stamatouli is an assistant professor of internal medicine in the Division of Endocrinology at Virginia Commonwealth University, Massey Cancer Center and Bone Marrow Transplant Clinic. Her work involves the management of endocrine cancers and endocrine complications related to cancer treatments, including bone marrow and stem cell transplantation and CAR T-cell therapy. Please join me in welcoming Dr. Stamatouli.
Hello, everyone. Thank you very much for the introduction and the invitation. It is an honor to be part of this meeting. So I specialize in oncoendocrinology, and as it was already said, I have a clinic embedded at VCU Bone Marrow Transplant Clinic. So I have been taking care of bone marrow transplant patients for the past 6 years. Today, though, we will discuss about bone health after stem cell transplant. Due to recent advances, the stem cell transplant is now safer, which means that more people are having these transplants and living longer after the treatment. One of the long-term health concerns for people who have had a stem cell transplant is the risk of bone weakness, which can eventually lead to fractures. So because of this risk, it is important for all the patients to have their bone health monitored more closely over time. So my goal today is to provide some helpful information about what should patients do after transplant to decrease the risk of fractures. I have no relevant financial interest to disclose. Specifically, we will try to define low bone mass, or also osteoporosis, discuss about bone health after transplant, what are the risk factors for bone loss after treatment, how to monitor bone health after transplant, what diet and lifestyle interventions to follow to improve bone mass, and lastly, we will briefly discuss about treatment for osteoporosis. So what is osteoporosis? Osteoporosis is derived from the Greek words osteo, that means bone, and porous, that means pore or passage. So the combination of these two words indicates a condition when bones become full of holes, more likely to fracture. Osteoporosis is quite common in the general population, and especially as people get older. So in fact, in the United States, about half of women and a quarter of men over the age of 50 will experience a fracture due to osteoporosis. Around 300,000 people break their hip each year. Unfortunately, hip fractures can lead to serious consequences. So 1 out of every 4 people who suffer a hip fracture may pass away within a year of the injury. Another 1 in 4 might need to move into a nursing home after their hospital stay and may not be able to return home. Additionally, half of those who experience a hip fracture might not be able to regain their previous level of independence and mobility. Looking to the future, the number of fractures each year is expected to increase significantly, from 1.9 million in 2018 to 3.2 million by 2040. This increase will also lead to a rise in healthcare costs from $57 billion to over $95 billion annually. So we understand from these statistics that the importance of taking steps to prevent bone loss. So this is a question that I frequently take from my patients. What are the symptoms of osteoporosis? So osteoporosis is called a silent disease because it doesn't usually cause symptoms. The symptoms are usually related to complications from bone loss. Patients could present with fractures with minimal trauma. So they might break a bone from a small accident or fall that wouldn't normally cause such an injury if the bones were healthy. A patient might notice that they're getting shorter over time, and this can happen because the bones of the spine could become compressed or fractured. Patients could experience sudden back pain or tenderness. Again, it could be due to a fracture in the spine. They could also notice some change in the way that they stand or they walk. They could also lose their mobility, and specifically when fractures lead to difficulty moving around and performing their daily activities. So in general, as we age, and this is a normal process, we usually lose bone density. However, after undergoing cancer treatments, including stem cell transplants, the rate at which bone loss occurs is much faster and a little bit more pronounced. This means that within just 1 year after transplant, the amount of bone density loss can be considerably more from what it could happen because of natural aging. As we can see in this table, we can see the bone mineral density loss, the percentage at 1 year. We can see the bone marrow transplant could cause 3.3% loss in 1 year, whereas in normal aging, we can see much less percentage. There is a reported incidence of bone loss of about 50 to 75% after allogenic stem cell transplant and 20 to 65% after autologous stem cell transplant. The majority of bone loss occurs within 3 to 6 months after transplantation. So it could happen quite soon after the treatment. So what are the risk factors for bone loss in stem cell transplantations? Some baseline risks are similar to the general population. So genetic or other conditions could contribute to bone loss. So age could play an important role, race, sex, women more commonly than men, menopause as a situation, family or personal history of fragility fracture, low body weight, history of osteoporosis due to endocrine disorders that could and coexist with cancer. For example, patients could be having elevated cortisol levels or elevated parathyroid hormone levels even prior to their diagnosis with cancer. History of rheumatoid arthritis and other autoimmune conditions, history of chronic kidney or chronic liver disease, history of sickle cell or disease or multiple myeloma. Patient's lifestyle could also be playing a role. So if a patient is actively smoking, if a patient consumes excessive amount of alcohol, more than 3 drinks a day, or if a patient follows a sedentary lifestyle, could all contribute to bone loss. On the other hand, cancer by itself as a medical condition or cancer treatments could also contribute to bone loss. Chemotherapy could be very toxic to osteoblasts and bone marrow cells, which are the construction workers of the bones. So it can potentially damage the ovaries or the testicular tissue, leading to reduced production of hormones like estrogen and testosterone. So this can result in the onset of menopause for women earlier than usual, earlier than the age of 40, and low testosterone in men. Radiation can also lead to bone loss. The use of glucocorticoids such as prednisone or dexamethasone, and specifically when they are used for a longer duration, more than 3 to 6 months, or medications that have been used for the management of GVHD, such as calcineurin inhibitors. One example of these medications is tacrolimus, that probably some of you might have been taking already, could also lead to bone loss. In some situations, patients who have malnourishment, either due to nausea because of chemotherapy, for example, or they experience cancer cachexia, could also have risk for bone loss. Cancer cachexia is a condition where patients, because of cancer, they lose a lot of body weight, and that eventually results either in loss of muscle mass as well as fat. Some patients also could experience fatigue because of their underlying history of cancer, and that by itself could reduce physical activity and eventually muscle and bone. Patients who develop graft-versus-host disease also they're at increased risk of bone loss, and also patients who have been taking a lot of transfusions resulting in iron overload could have some detrimental effects on their bone. So how should we monitor bone health after a stem cell transplant? And this could be monitored very well with one test that is called bone density scan. So what is a bone density scan? It is an imaging test that measures bone mineral density in the spine, hip, and occasionally the wrist. It is a non-invasive procedure and it helps us understand the risk of fractures and monitor any changes in bone density over time. So what to expect during a bone density scan? During the scan, usually the patient lies on a padded table while a machine passes over their body. The scan is painless, and it typically takes about 10 to 20 minutes. So it's a short time interval. The amount of radiation used in a bone density scan is very low, much less than a standard chest x-ray, making it a safe procedure. Patients can eat normally on the day of the test, but they may need to avoid taking calcium supplements for 24 hours before the scan. Patients should usually wear comfortable clothing without metal zippers or buttons. So after the bone density scan, the patients receive a report that includes some key numbers and terms. Some of you might have already had the scan. So let's go through how we can interpret these results. So here's the first score that we are evaluating is usually for women that are either menopausal or for no matter what is their age group, and for men that they're over the age of 50. And this is called T-score. The T-score compares the bone density to the average peak bone density of a healthy young white female. A T-score of -1 or above is considered normal. A T-score between -1 and -2.5 indicates low bone density or osteopenia. And a T-score of -2.5 or lower suggests osteoporosis, meaning that the bones are more fragile and at higher risk for fractures. Now, for patients who are younger than 50 years old, we're using a different score. It's called Z-score, which compares actually the bone density to what is expected for someone of the same age, gender, and size. A Z-score below -2 may suggest that something other than aging is causing bone loss, and further investigation might be needed. In addition to the bone density scan, we use the FRAX tool. This is a risk assessment tool that helps us estimate the risk of experiencing an osteoporotic fracture. This tool hasn't been specifically validated for cancer patients, but we definitely use our clinical judgment when we try to interpret the results. The FRAX is designed to be country-specific, meaning that it incorporates the specific epidemiology of osteoporosis, and the fracture risk factors are unique to each patient's country. This tool takes into consideration several risk factors, including patients' age, sex, weight, height, smoking habits, history of rheumatoid arthritis or other autoimmune conditions, or if there is a history of fractures to the patient's parents, the use of glucocorticoids, among others, and it calculates the 10-year probability of a major osteoporotic fracture. And when I'm saying major osteoporotic fracture, I mean a non-traumatic fracture that occurs in one of the key sites that are more commonly affected by osteoporosis, either the hip, the spine, the wrist, the shoulder. It also calculates the 10-year probability of a hip fracture. So definitely it helps us specifically for patients who are having osteopenia or they're in this intermediate situation where they don't have osteoporosis, but we want to understand their risk in order to determine whether or not treatment should be used. Except for the bone density scan during visits, we perform some additional testing. We're doing some helpful blood tests, but we're also ordering X-ray of the spine to evaluate for possible fractures, especially if the patients complain of very severe back pain. We try also to set up some frequent visits with the provider and the patients to discuss about possible complications, but also the risks and benefits of treatment. So which interventions are effective in reducing the risk of osteoporotic fractures? The first step is to make sure that we optimize calcium intake. So our goal is for each patient to take about 1,000 to 1,200 milligrams of calcium from diet, if it is possible, and supplements when we have to. So I usually provide this leaflet. This is coming from the International Osteoporosis Foundation. It's a 2-page leaflet which shows the calcium content proportion of some common foods. This is available in their site and it could be downloaded for free. If patients cannot take enough calcium through their diet, then supplementation is advised. The 2 main forms of calcium in supplements are carbonate and citrate, and it does play a significant role which one we will choose based on each patient. So calcium carbonate is more commonly available and is absorbed more efficiently when taken with food. The calcium citrate is absorbed equally well when taken with or without food. We should be more cautious when we are suggesting for one patient to take calcium supplements, and because like in general, we have to limit the calcium intake from supplements between 500 to 600 milligrams per day. The reason is that high intake of supplements could increase the risk for kidney stones. Now, there are some situations where patients could be having history of malabsorption, or like they might not be taking increased calcium through their diet. So in this situation, we might change our daily recommendation for a supplement in order to meet like the cutoff of 1,000 to 1,200 milligrams. But in general, we try to avoid that so that we would decrease the risk for kidney stones. For patients now who have malabsorption or are on proton pump inhibitors, calcium citrate is suggested for better absorption. The second step is to optimize vitamin D supplementation. And why is that? Vitamin D is crucial for bone health because it does help with calcium absorption from food in the intestine. It helps with bone mineralization and also reduces the risk of falling. We usually recommend a daily dose between 1,000 to 2,000 units per day for patients who have adequate supplementation, or to maintain levels in general of vitamin D between 20 to 50 nanograms per ml. I'm using this range because like there are different opinions about what should be an optimal level in the blood based on different societies. My personal recommendation to my patients is to keep a level between 30 to 50 nanograms per ml. I also provide my patients this table from the International Osteoporosis Foundation, which shows the vitamin D content proportion of specific foods. Third step is to introduce or optimize exercise in our patients. And again, exercise is very important because it improves strength, posture, and balance, and also decreases the risk for falls. We know that some patients, like after the bone marrow transplant, they might be very sick, so they might not be able to participate in physical activity. So I very frequently recommend to have a physical therapy evaluation after transplant to individualize for each patient, like the exercise plan, like the type of exercise that they should follow and the intensity of them. But in general, for patients who have low bone density, we suggest weight-bearing exercise such as jumping, skipping, bench stepping, and resistance exercise like weight training, push-ups, resistance band exercise. When it comes down to weight training, we usually suggest low weight training. We suggest to avoid forward bending and lifting weights over 10 pounds overhead. Of course, if a patient has like a very good physical condition and like they have been training for a long period of time, they might be able to lift like more weight, but in general, we're trying like to limit, and specifically for patients who have severe osteoporosis, we're trying to limit the amount of weight that each patient should lift. In addition to the above, we suggest patients to follow a balanced diet, low carbohydrate, high protein, stop smoking, limit alcohol intake to less than 2 drinks per day, lower the dose of prednisone or other steroids if it is possible, of course, and maintain good vision. Lastly, I provide some information to patients of how to fall-proof their home. Again, this comes from the International Osteoporosis Foundation. And what I suggest to patients is to try to remove objects that they can trip over, light well all the areas of the house, repair loose carpets, install handrails by the bathtub or shower, and keep items at an easy-to-reach level. Now, when should we start pharmacologic treatment? So I will try to discuss some of the indications based on the latest expert panel opinion for bone health management after stem cell transplant from the American Society for Transplantation and Cellular Therapy. And in general, the recommendations like divide the patients into two major groups, the one who have not received glucocorticoids for GVHD and the ones who have received glucocorticoids. So for patients who have not received glucocorticoids for GVHD, we start usually pharmacological treatment if the patients have history of fragility fractures after the age of 50 years old. And again, as a reminder, fragility fractures or osteoporotic fractures happen when bones are weakened by osteoporosis and can break easily even from minor impacts or falls from own height. We usually suggest in postmenopausal women and men who are older than age of 50 years old and they have femoral neck, total hip, or lumbar spine T-score or minus 2.5. For patients who are older than 40 years of age and they have a T-score between -1 to -2.5, but have higher FRAX score, specifically, they have a 10-year probability for major osteoporotic fracture more than 20%, or a 10-year risk factor or risk of hip fracture of more than 3%, we again suggest treatment. Now, for patients who received glucocorticoids for GVHD and they are older than 40 years old, again, we would suggest treatment if they have history of fragility fractures. Again, for men who are older than 50 years of age or postmenopausal women, they have like a femoral neck, total hip, or lumbar spine T-score of minus 2.5, so more negative than that. Or when they have like fracture risk of major osteoporotic fracture more than 10%, so we use like a lower threshold compared to patients who are not on steroids, and a 10-year probability of hip fracture more than 1%. As a reminder, it was 3% in patients who were not on steroids. For patients who receive glucocorticoids and they are younger than 40 years of age, again, we suggest treatment if they have fragility fractures, or if they have hip or lumbar spine Z-score. As a reminder, Z-score is what we're using in people in the younger than age 40, and they're having like a Z-score of -3 or lower, or if they have rapid bone loss more than 10% at the hip or their lumbar spine over 1 year. Obviously, these patients are receiving usually high doses of steroids, and specifically they're on steroids, and prednisone is our reference, of more than 7.5 milligrams every day for more than 6 months. So what are the osteoporosis medications? So in general, the primary goal of osteoporosis medications is to strengthen the bones and reduce fracture risk. We have 3 different categories of these medications that we use in general. The first category is called anti-resorptives, and what they're doing is they're slowing down the bone-resorbing cells, which break down the old bone, allowing the bone-building cells to work more effectively. So they're strengthening the bones and they reduce the fracture risk. The second category are called anabolic medications, and what they're doing is that they're stimulating the bone formation, leading to stronger bones, and they decrease fracture risk. The third category are the hormonal medications that may improve bone density, specifically when estrogen and testosterone levels are low in women and men, respectively. Here are some examples of some of the medications in each class. For anti-resorptives, bisphosphonates are the ones that they have been used more frequently. They could be oral, for example, alendronate or isendronate, or they could be given through the vein. and the most common one is zoledronic acid. Denosumab is also in this category and is being given through an injection every 6 months. When it comes now to anabolic medications, we're having here again 2 different medications. One are the PTH or parathyroid hormone receptor agonists, such as teriparatide or abaloparatide, and the other medication is called romosozumab. For hormonal treatments, raloxifene is the one used in some other populations that have like breast cancer, and also estrogen for females and testosterone in males. From the 3 categories of medications, the use of antidisruptive medications is suggested as first choice, and in some situations, a hormonal treatment. The anabolic medications are not routinely suggested due to lack of efficacy and safety data. But if we feel that, of course, in some situations, anabolics should be used, we should evaluate the risks and benefits for the patient before starting them. So let's go with the first class. The antidisruptive medications. Again, as we discussed, this is the first-line therapy for prevention and treatment of osteoporosis in stem cell transplant patients. They're important for some patients with multiple myeloma, and they might be using them before and after stem cell transplant. When we use these medications, we want to ensure that calcium and vitamin D levels are at goal before and during treatment to prevent low calcium levels a few days after the administration of the medication. Of course, all the medications have some toxicities that we should be aware of. The oral bisphosphonates can cause inflammation of the esophagus, and so we usually provide some specific instructions of how patients should properly take these medications. We suggest to take them with empty stomach, take them in the morning, try to not lay back in bed, like just stand or sit, and take them with plenty of water. The intravenous zoledronic acid can cause flu-like reaction after administration, so we advise patients to take acetaminophen before the infusion and for 48 hours later, and try to keep themselves like well hydrated. Both the oral bisphosphonates and the intravenous zoledronic acid are not safe in patients with advanced kidney disease. In this situation, we are using the other medication called denosumab. The denosumab, as we said before, should be given every 6 months. If we delay or we have to discontinue the medication, that could increase the risk of fractures or worsen bone density, so we have to be very cautious of how we stop this medication. Another toxicity is like, which is kind of like late onset and quite rare. It's called like atypical femoral fractures. This is like very common in oncology patients. And these fractures occur usually in the thigh bone, in the femur, just below the hip joint or in the middle of the thigh, as we can see in the X-ray on the right side. They're considered atypical because they happen in an unusual part of the bone and often with little or no trauma. So why do the patients develop this complication? Because usually the antidisruptive treatments in general, and specifically the bisphosphonates, work by slowing down the natural process of bone breakdown, which can lead to changes in how bones repair themselves over time. So this over remodeling process may increase the risk of atypical fractures in some cases. So in this situation, we are limited bisphosphonate use to 3 to 5 years, unless if there is a different condition that we need to extend their use, or we have to use them more frequently. Another complication is called osteonecrosis of the jaw. The osteonecrosis of the jaw is, again, a very late and rare complication, and it's a condition where the jawbone starts to weaken and die due to lack of blood supply. This can lead to exposed bone in the mouth that does not heal properly. Antidisruptive treatment can affect the ability of the jawbone to repair itself, and specifically after dental procedures or trauma, by altering the normal bone remodeling process. There are different risk factors that could contribute to this, like dental procedures, and specifically the invasive ones, such as tooth extractions or implants, could increase the risk. or the duration of use of all the antidystrophic treatments also increase the risk of osteonecrosis of the jaw, such as poor oral hygiene, even before the initiation of the treatments, smoking, or pre-existing dental conditions could also contribute to the risk. It is more commonly found in patients who are taking denosumab, and what is suggested is a comprehensive dental exam and elimination of oral infections before starting antidystrophic treatment in order to prevent this complication to happen. Except for low bone mass, another complication after stem cell transplant is the avascular necrosis. Avascular necrosis is also known as osteonecrosis. It's a condition where bone tissue dies due to lack of blood supply. For joint pain when they move, for joint pain even when they are at rest, and they might be having limited range of motion. The management of avascular necrosis is usually handled by other specialties, for example, orthopedics, so we won't discuss about treatment options here, but definitely this is something that most of our patients need to be aware. So in summary, what do we discuss today? What do we have to take our points? Bone loss is very common after stem cell transplant. There are multiple risk factors that are associated with bone loss. They could be genetic, they could be related to patient's lifestyle, they could be related to the cancer treatments per se, or the cancer by itself. Regular monitoring for bone loss is essential before and after stem cell transplant. Dietary modification and lifestyle changes are very crucial to prevent bone loss and improve bone health. Bisphosphonates are the treatment of choice for managing osteoporosis. So thank you very much for the time and attention. So I would like to open the floor for any questions you may have.
Thank you, Dr. Stamatouli, for that excellent presentation. Very comprehensive. We do have a lot of questions, and we're going to try to get to as many of them as possible.
Sure.
The first question is, does CAR T-cell therapy affect bone health? This person has noticed that her posture is affected after CAR T. She's leaning forward more often and wonders if this is due to some bone issue.
Well, this is a great question. Definitely that should be explored either from the oncologist, and if they do have an endocrinologist, by doing a bone density scan to assess their bone loss. CAR T therapy can definitely affect the bone, and so not to the same extent as the stem cell transplant, but definitely could have some effect. So I would definitely suggest that. Also, I would suggest to perform an X-ray of the spine to make sure that this change in posture is not due to an underlying fracture that has already happened. It might not be related actually to the CAR T treatment. It could, underlying disease.
Okay. This person wants to know, once diagnosed with osteopenia, can that be reversed?
Definitely. That's something that's why we need to detect early low bone mass, because this way we can have a full evaluation. We can definitely make some changes in lifestyle, as we discussed before, try to optimize calcium and vitamin D intake, try also to introduce some exercise, and in some situations, if there is a higher risk for fracture, we could suggest treatment. We use some of the treatments that we already discussed, and the frequency might vary, but we do suggest it in some situations in order to prevent further bone loss.
All right. The next question is, can you clarify what the difference is between osteopenia and osteoporosis?
So this is like based on the bone density scan, as we said before. Osteoporosis obviously is like a condition where like the bone is becoming a little bit more porous, so like and definitely it's more it's a higher risk for fractures. That's why we suggest treatment. Osteopenia is I usually use the term gray zone, as I said to my patients, in the sense that it's like it's not, the bone density is not normal and it's not in the level of osteoporosis. But in this zone, we're usually assessing other risk factors where like a patient like could have low bone density and could, based on the risk, we can determine how to further manage them. So it's like an intermediate situation where you do have bone loss, but not to the point that the bone is very porous.
Great, understood. The next question is, do you recommend a DEXA scan more frequently than Medicare allows?
That depends on the circumstances. So just like a reference for some patients that are not the insurance is not Medicare. Medicare usually allows a bone density scan every 2 years. But in patients who have like bone marrow transplant, we could suggest, and specifically if like they are on treatment or if we know that they are having higher risk for fracture and we want to protect them and early detect like when we should initiate treatment, we could like request the bone density to be ordered more frequently every year. Once a year is enough, I believe. And again, after like, of course, justifying why we request that, sometimes Medicare could cover it.
Oh, that's good to know. This gentleman wants to know, when do you do your first DEXA scan after an autologous stem cell transplant? And he also wants to know, how does Zometa figure into maintaining bone density?
So first of all, our general practice VCU is like we usually order the first bone density scan 1 year after transplant, but theoretically 6 months after the autologous stem cell transplant, like we could potentially order a bone density scan to detect like potential bone loss. And so the medication Zometa is like it's the intravenous form of antidisruptive medications that we discussed before. It's called like zoledronic acid. And as we said, that these medications are medications that they slow down the bone resorbing cells. They're called osteoclasts, which they break down the old bone and they allow the bone building cells, which are called osteoblasts, to work more effectively. This way, they strengthen the bones and they reduce the fracture risk.
All right. This person wants some clarification on why you recommend avoiding bending and lifting weights over 10 pounds over their head. Is that a lifelong precaution, a temporary precaution?
So this is a precaution that our patients should take specifically when they are at very high risk for fractures, because if they're lifting like a specific abruptly, like a very increased amount of weight, there is a risk that they could cause further fractures. This could be, this like precaution should be taken for the period of time that the bone heals and as we are managing like low bone mass. When a patient is in a safe range, of course, and as like they are increasing like their stamina and like they're increasing like their strength, obviously this like cutoff could change.
Okay. This person wants to know whether arthritis affects osteoporosis.
I'm sorry, I couldn't hear you very well.
Oh, this person wants to know whether arthritis affects osteoporosis.
No, not directly. Arthritis is a different situation. Actually, if a person has rheumatoid arthritis, this could be a risk factor because it's an autoimmune condition. But if a patient has osteoarthritis, which I mean, that probably this is what patients usually asking. Like in this condition, this is a separate situation. Obviously, it doesn't have direct effects, but indirectly, if a patient has severe osteoarthritis and are not able to be active, that eventually could have like some detrimental effects on the bone, but there is no direct relationship.
All right, this gentleman wants to know, when supplementing vitamin D, should you also supplement vitamin K2?
This is suggested in some situations, but I'm more cautious with vitamin K replacement, specifically for patients who have history of blood clots, because definitely could have like some effects in the blood clotting process. So I would be very careful and I would ask like my provider whether or not like the replacement of vitamin K would be helpful and safe.
This person wants to know specifically which blood tests are used to determine bone health.
So that's a very good question. Thank you. So usually, like when we start the evaluation, we always want to check like calcium levels for every patient, the vitamin D levels, the renal function. We'll check like liver function tests, and specifically like one test that is called alkaline phosphatase. This shows like, whether or not like some patients could be having like some conditions that could increase like this, the bone turnover. We're assessing the thyroid function and also one hormone that is called parathyroid hormone that plays a crucial role in the bone metabolism.
All right, thank you
of
for
course,
that.
Sometimes we individualize the workup and we do some more specialized testing, but this is where we start.
Gotcha. All right, the next person wants to know, if they're diagnosed with osteopenia and are on continued prednisone, is it expected that the osteopenia will progress to osteoporosis?
Well, this is definitely a risk. So I would suggest to discuss based on like their bone density results and the amount of steroids that they have been taking. They need to discuss with their providers in order to determine when to initiate treatment to protect their bones. And obviously, I would definitely suggest to take optimal calcium and vitamin D supplements.
Next question is, can you recommend which calcium and vitamin D supplements specifically we should use? If not, what should we be looking for in evaluating different brands?
I usually do not discuss about brands with my patients, but what I suggest is I usually try to get to know my patients to understand which calcium supplement it would be ideal for them. As we discussed, like there are two different forms, like calcium carbonate and calcium citrate. If a patient, for example, takes medications to control reflux, they're called proton pump inhibitors, omeprazole, pantoprazole. I usually suggest calcium citrate. Also, this is a form that I would suggest in patients who have history of malabsorption, because it has been found that this could be helpful. So definitely, like I try to understand like their background history in order to determine which supplement will be optimal. When it comes down to vitamin D intake, I usually prefer like the daily replacement. It has shown in studies that it's preferred. And again, the amount of vitamin D depends on the underlying vitamin D level, and also like what is the risk for falls and underlying past medical history of the patient.
All right, thank you for that. This person wants to know if you could talk about butyrate and its impact on osteoporosis.
I'm sorry, can you please repeat your question?
Yes, this gentleman wants to know, and I may be mispronouncing this, if you could talk about butyrate, or maybe it's butyrate, and its impact on osteoporosis. Butyrate.
So actually, the butyrate is a fatty acid And this has been linked in bone health, and specifically like in osteoporosis, but the data that we have like are not very strong. Definitely like they do have like some effect on the bone, but we don't have like very good studies to say that whether or not like this could be like a direct like relationship that we could support for our patients.
Okay. What are your thoughts about using a weighted vest for osteopenia?
Well, again, this is a very controversial topic of whether or not like this vest could be used. Definitely, there is like some positive effects, and specifically they have been found like in some animal studies and like in some studies in humans. I would say that I would discuss again like about the specific vest and the brand that the patient has, and I would definitely try to ensure that the impact on the spine will be low. Will not have high impact, but it could have a potential positive role.
All right. This woman said she also she had osteoporosis before she started cancer treatment, which included steroids. She has a stem cell transplant scheduled for this summer. Should I ask for a bone marrow scan before my transplant? Which of my doctors should I go to for my bone concerns? My primary care doctor, oncologist, or a transplant specialist?
That's a very good question. So this is actually something that we do suggest that for patients who already have some risk factors, having a baseline bone density definitely should be very, very helpful. This way we can determine, like how severe the bone loss is and try to be protective. Sometimes we don't initiate treatment just before the stem cell transplant just to avoid complications before the transplant, but definitely like, we could optimize and change the lifestyle in order like to prevent as possible like further bone loss. Now, the specialty, like everybody could order a bone density scan, meaning the primary care physician, OBGYN, or the oncologist. However, if there is an already pre-existing osteoporosis and you need more advice for management, I would suggest, like to visit either an endocrinologist that could have like more experience with cancer patients. And in some institutions, rheumatologists are also assessing bone health.
All right, thank you. The next question is, can decreased bone mass weaken my teeth as well?
I think that's a good question. So not directly. In other words, in patients who have been having like a history of osteoporosis, they could have like some effect on the bone, meaning that they might have some bone loss that could extend to the jawbone, and that could eventually result to dental issues. Some patients complain for tooth loss, or they might have like some periodontal disease, or they might have like impaired healing after dental procedures, but there is not like direct relationship.
Okay. This gentleman wants to know, how often should a person with multiple myeloma get Zelendronate infusions after transplant?
So actually the alendronate is a medication that is being given through the mouth. Probably what we mean here is like the zoledronic acid that is given through the vein. And for patients with multiple myeloma, it's called Zometa. This is actually a question that I cannot answer because this depends on the underlying condition, like the multiple myeloma itself. There are different protocols that the oncology team has been using, and the frequency depends on the disease. Some patients, like they have been taking it monthly, some patients every 3 months, or some patients every 6 months. So I would definitely have a discussion with the oncologist in order to determine the frequency.
Next question is, are whole body vibration devices good for osteoporosis or avascular necrosis?
So again, I would be very cautious with these devices because, as we said before, these like devices definitely could have some, if it could be beneficial for individuals that they have osteoporosis. Definitely could increase the bone density and reduce the risk of falls. However, it's very crucial to use these devices, but with low intensity vibrations. And I would discuss again with like my team whether or not like you could consider starting these programs, but they're not like very clear. The literature is not very clear about like the benefit of these devices.
All right, this person has another endocrine question. She asks, is secondary adrenal failure common after BMT for AML arising from CMML? She's experiencing currently this problem, wants to know what your recommended treatment plan for this is in light of severe osteoporosis also being present.
Yes, that's a very good question, actually. So, first of all, secondary adrenal insufficiency is a condition that could happen in patients who have been taking for a long period of time higher doses of steroids from what their body makes. So, usually, if a patient takes like more than, I will use like prednisone as an example, more than 7.5 milligrams for more than 3 months, they could have actually more than 3 weeks. They could have like increased risk for secondary adrenal insufficiency, and specifically when they take it longer for more than 3 to 6 months. So this could be a situation that could happen independently of the underlying condition. Like it's not happening only in AML. It could happen like to all the patients who have been taking high doses of steroids. This is a very it's very crucial, actually. It's a very serious situation. We definitely need to replace the steroids because the patients could be at risk for adrenal crisis. So we definitely recommend to take the lowest possible dose of steroids in order to prevent them from having other complications. In this situation, because the steroids are very crucial for life, I would definitely suggest to continue to take them. And down the road, I would reevaluate whether or not like the adrenal glands are starting to work again as like the patient is taking like the minimum dose of steroids. And I would try, if possible, to eventually wean myself off the steroids. But that should be done after the guidance of the treatment team that the patient is being managed from, and actually should be done after reevaluating the access. But in general, though, if a patient takes a dose of steroids that is close to what their body makes, it doesn't have like so detrimental effects on the bone as like with high doses of steroids.
All right. We've got a couple questions from people who want to know what the role of Prolia is in treating osteoporosis.
So Prolia is again a very good medication because it could help the bone to increase bone mass in the spine and in the hip. This is a medication that we are using specifically for patients who having like renal dysfunction, or like when patients, we discuss like the risks and benefits, and patients are electing to start with this medication. I think what it is very important is to understand that this medication, even though it is effective, like needs to be handled with caution. The reason that I'm saying that is because if you stop abruptly this medication, you could reverse what you have achieved so far with the treatment, and actually you could have increased risk of fractures. So definitely it's a good option, definitely something that we should consider for every patient treated with osteoporosis, but I would definitely like have a discussion about the duration, how long you need to take it, and also how you will be weaned off the medication.
All right, understood. The next question is, does bone loss, following stem cell transplant stabilize after the first year?
Well, it depends, because usually it's not just the stem cell transplant. There could be other risk factors that could be also contributing to bone loss after the 1-year cutoff point. As you know, some patients could experience GVHD. This is a condition where patients require high doses of steroids. So sometimes these factors could also contribute to bone loss. In this situation, what I usually suggest is to just monitor the bone density until we don't have other risk factors that further decrease the bone mass. However, in patients who do not have other conditions, and if we take it as an isolated situation, just the bone density, in some situations, yes, bone density could be a little bit more stable just because patients are recovering and they're able to participate, they prevent their nutrition, they're able to participate in exercise, and of course, they're feeling much better.
Okay, and this will need to be our final question. Does tacrolimus contribute to bone loss?
Yes, it could have some effect on bone cells as well.
Okay. With that, we're going to have to wrap it up. Our time is up. I want to thank Dr. Stamatouli for an excellent presentation, and for the audience, thank you for your questions. This was an excellent question and answer session. Please contact us if we can be of any